Okay, good afternoon. Thank you very much for being here to this special lecture by Dr. Raul Pelayo. He is a friend of mine. I am usually a neurologist for who don't know me. We are neurologists that we deal with patients, and we meet a long time ago in Valdebrón. Raul is a neurologist that finished his degree in Valladolid and then made his specialization in neurology in Valdebrón, where we meet and we spend some time treating patients with MS, with multiple sclerosis. But then he moved to Institut Guttman, that is a well-known hospital, one of the most important rehabilitation hospitals in Spain, in Catalonia, in Spain and in the world, very well known for this institution is specialized in rehabilitation, both physical and cognitive, and they treat patients mainly affected by neurological disorders in the spinal cord or in the brain, affected by brain injury. They treat patients with, let's say, common rehabilitation, but they are also doing a lot of research with new techniques, new approaches to improve patients regarding rehabilitation. He is an expert in non-invasive brain stimulation for rehabilitation in neurological diseases. He visits everyday patients. He sees what the patients need in terms of rehabilitation, and he's involved in different projects, in different new techniques and research with new approaches for neurorehabilitation. For those of you who were maybe 1 month ago here, we had Aloy, who is engineering, working together with neurologists and other health professionals in Institut Guttman. And now we have Raul, who is a neurologist, working all together with a different multidisciplinary team, all together working to improve the quality of life of patients affected by neurological disorders. He will make this lecture around non-invasive brain stimulation, but in a theoretical field, but also sharing with all of us his experience in Institut Guttman with treatments that they are doing and research that they are doing. And I think that for you, for engineers, medical engineers or general engineers, I think that will be useful for ideas and for to see how in your field can help us as health professionals to improve problems with real patients. So Raul, thank you very much for being here and to come from Barcelona to here, and we are happy to listen to you. Thank you very much.
Thank you. I would like to thank the possibility to stay here, especially my friend Dr. Ramiro. As usual, my audition are doctors or patients, but I have some training because in the last 2 years we start a master degree with the Politècnica of Barcelona. But perhaps do you have some question about some specific device or some specific technique? Perhaps it's better to ask a low episode that I stayed here 4 weeks ago, I think. Perhaps it's better, and if you have some question, I translate the question to a low episode, okay, about technical questions. I am a doctor, I'm a neurologist, and my practice is usual medical practice. I don't know if you listened before something about non-invasive brain stimulation, because in medicine I think that nobody explains something about brain stimulation. Okay. First, I will clarify a concept, the concept of the plasticity. Everybody listen about the plasticity. Plasticity is good for recovery after an injury because you have a lot of plasticity, you improve a lot. Then I want to clarify that plasticity is not a positive concept per se for itself. Sometimes it's possible an adaptive plasticity and the patient improve. But sometimes it's possible an non-adaptive plasticity. In this case, the patient don't improve and sometimes worsen. Then we need an adequate amount of plasticity. Because logically hypoplasticity is not good, but hyperplasticity produces non-adaptive changes. Then our challenge is to arrive to these two checkpoints, to measure the plasticity and to modulate the plasticity. And non-brain stimulation helps us to get these two checkpoints. How we could change the plasticity? Logically with rehabilitation. And the base of the rehabilitation is the same than since the Second World War. To rehabilitate the walk, we need walking. And this is the parallel bars. Now, the patients in Guttman, when they want to improve the walking, they go for the parallel bars, like this photography of the Second World War. But logically, in the last years, we have some tools that help us to improve the rehabilitation targets. Robotic, this is the, I don't know, but perhaps Eloy explained Arameo. Arameo is an arm robot. They have the possibility to move in different angles, the arm, okay? The robots perhaps not better than manual therapy or the physiotherapy, but let us to repeat, to reproduce, and to measure best our rehabilitation. Or virtual reality that is possible to create environments in the rehabilitation room. We start to change some concepts of the rehabilitation. This is a technique, constraint-induced therapy. Constraint-induced therapy, the patient constrains the injury arm, and the patient makes exercises on rehabilitation with the injury hands for 4 hours, 5 hours, 6 hours to try to improve the functionality of the arm. And drugs. The problem with the drugs are not specific for change the plasticity, are not focal, and sometimes drugs are responsible of the non-adaptive changes. Okay. And then the electricity, okay? As a dream of the humanity to use electricity to change or to improve in medicine. I would like a lot of classical science fiction. This is the, this is the classic of the Universal, the monster of Frankenstein in the 30s. We use the electricity of the storm to revive the monster, okay? But we could use in this moment electricity in medicine. For example, electroshock. When people listen to electroshock, everybody think in Jack Nicholson. I think in Spanish is the film. In Spanish is Alguien voló sobre el nido del cuco. I think that is One Fly Over the Cuckoo's Nest, or similar, the name of English. But now, electroshock is useful. In psychiatry, principally in depression, sometimes it's possible to use electroshock. Not like in the film, which is monopolar, with anesthesia, okay? But logically, it's niceless. And produce some problems. For example, loss of memory. Logically, we have invasive devices. For example, vagus stimulator, vagus micropiece, okay? Or for example, DBS for stimulation in Parkinson disease. But logically, we want to create or modify electrically the brain, but in non-invasive form and a painless form. Then we have non-invasive brain stimulation. Okay? Non-invasive brain stimulation, born in 1985. This is the Anthony Barker. He is professor in the Sheffield University. And this is the representation, theoretically, this is the first TMS, the first transcranial magnetic stimulation. Dr. Baker, he is Dr. Baker, she is the fellow that received voluntary the first TMS. Well, we talk here about principally two techniques. Transcranial magnetic stimulation. Transcranial magnetic stimulation uses a coil. The coil produces a magnetic field, and magnetic fields in the same time produce an electrical current in the brain. Okay? And the other technique is transcranial direct current stimulation. It's difficult to explain how transcranial direct current stimulation works, because dially is only a battery with 2 electrodes and produce dially only 2 milliamperes of intensity. And I try to ask after how it's possible that only with 2 milliamperes is possible to induce changes. Well, I say this part of the, I say because I have this part of the presentation because I am doctor and you are engineers. I have to explain Faraday, you know. Sorry, because I have some mistake about Faraday, no? But transcranial magnetic stimulation is based on the Faraday principle. Okay? Faraday say that, this is the original drawing of Faraday. You pass a current for a coil, and you produce a magnetic field, a perpendicular magnetic field for the direction of the current. You have a conductor near of this field. We reproduce an electric current in this conductor. Then it's a possibility to translate from the condensator to the brain electricity without the necessity to give direct electricity with the magnetic field. And it's not like you see in the TV magnetism or no. This is electricity, but to transduce electricity we use a magnetic field. And the induced current depends on, logically, the primary current intensity, but this is important, the coil morphology. The first coils are this kind of form, circular. You imagine a circular coil, you create a magnetic field, a big magnetic field, but no focal. Sometimes I'm interested to create a focal stimulation. How is possible to create a focal stimulation? With this kind of coils, 8 coil or butterfly coil. I try to explain you for physics. We have this kind of 8 coil, the center of the coil touch the scalp, okay? And the borders of the coil don't touch. I have a distance with the head. The intensity of the magnetic field is proportional to the intensity of the current, but is quadratic inversely proportional for the distance, and lose all the energy because only with a few centimeters lose all the energy. This is the form that is possible to create a focal stimulus. The form of the coil depend of the neural network excitability level. The neural network depends, the excitability depends, for example, it's different in the morning and the evening. It's different according with the drugs that the patient take. It's different if you study a movement. Or if you imagine the movement, the network changes. So the network is not unstable. The network changes according with different internal or external stimuli. And logically, underlying anatomical substrate. The integrity of the scalp, of the skin, of the bone is important to to the result of the transcranial magnetic stimulation. Well, the first application for TMS is neurophysiological use. If it's possible to change the cortical stability with TMS, and it's possible to measure these changes, we can study, for example, motor function. This is the better here, okay. It's possible to study, usually it's easy to study the hand. Why? I don't know if you know the penfilo munculo. It's the representation of the body in the cortex. The representation in the hand is big and it's in this area. It's easy to arrive with the coil. Okay? And if you, for example, record with electrodes in some muscles of the hand, usually adductor pollicis brevis or first interosseous dorsal, and with electrodes it's possible to collect a motor evoked potential created for the stimulus in the hand area of the motor cortex. This is a patient with a stroke. We collect the motor evoked potential in the normal side. We have this kind of curve, motor evoked potential. Okay? But we have to stimulate the injury side. We have this small motor evoked potential. Sometimes we have no potential. We know that it's a question of the brain, because if you stimulate with the same machine, with say the coil, cervical area, we collect a normal motor evoked potential. If you have a motor evoked potential with the stimulate the cervical area, you have non-abnormal motor evoked potential when it stimulates the brain. The problem is in the brain, logically. I don't know if you know DTT. Diffusion tactography is a technique of MRI, the MRI technique that led us to have visual representation of the vias. In this case, via pyramidal, that is in relationship with the movement. In this case, of the movement in the hand. It's logical to think that we have an integrity of the via, we have a normal motor evoked potential, and you have a cut here because you have a lesion, and stroke, and tumor, etc. And we make a stimulus. The stimulus don't arrive here, and we have not a motor evoked potential. But it's not exactly, because when making studies, it's demonstrated that TMS have more specificity than DTT in demonstrate lesions in the pyramidal via. But DTT has more sensibility. Then perhaps we have better results if we add TMS and diffusion tactography. Okay? But what is the question? TMS is less expensive. It's possible to pour TMS in the head bed, in the room of the patient. MRI is more complicated, it's more expensive. We had to create this scheme to give a prognosis of the movement of the hand after a stroke. The patient has a stroke, and in the first week we have a stimulation and we collect a motor evoked potential. Probably the prognosis of the movement of the arm is good. If the motor evoked potential is negative, it's possible to make an MRI. And the diffusion are positive, perhaps the prognosis is not good, but probably the patient improves in the future. And if you have a negative diffusion and negative motor evoked potential, probably the prognosis is poor and the target of the rehabilitation is only palliative. Now there are groups that design and 3D in decision tree, sorry, to know what is the prognosis in the movement of the arm to design better the rehabilitation program. You have movement in the first week after the stroke, it's not necessary more proofs. You have the weak prognosis, okay? But you have not movement, make a TMS. There are motor evoked potential. Perhaps it's not the same evolution of this kind of patients, but he have a notable evolution. The TMS is negative. Make an study with magnetic resonance. There's positive DTT. Probably the patient improve, not a lot, but improve. And this negative, not improve. You have the follow-up, the different patients with this classification, and you know that the patient with negative motor evoked potential, in negative diffusion tactography, have a bad response, bad evolution, after 26 weeks after the stroke. Well, other question is, how is possible to drive the coil to the exact position? We use navigator system. The most used navigator system, we have this navigator, is branch side. It's a simple system. Use infrared camera. Now it's fixed in the wall, but it's possible to translate it with a case. Okay. We use these coils, these system coils. We put in reference these coils with the program with parts of the face of the patient. Usually, we put in reference these coils with the nation, tip of the noise on the 2 ears. It's logical to think that in the next day the patient has the noise in the same place. And we put in reference the coil with the center of the coil. Okay? And then with the program, it's a program for Macintosh. I don't know why, but for Macintosh, it's possible to localize the coil like a video game. Okay. Sometimes it's the real MRI of the patient, sometimes it's a phantom model. Okay. It's possible to, for example, to mark a target and drive the coil to the market, or the opposite, to move the coil and decide a target while we move the coil. Okay. Or for example, we have a functional MRI, I want to move the coil for the point that we marked with the fMRI. Okay? With this technique, it's possible mapping, to do maps, motor maps. Neurosurgeons sometimes do these maps, but it's necessary surgery to open the scalp, etc., etc. But it's possible in non-invasive form to make maps. We mark different points to collect the motor evoked potentials, transform these motor evoked potentials in a color maps, and it's possible to do a non-invasive mapping of a determinate muscle. Usually, we need to move the coil with the hands. But a few months ago, we acquired this robot. This is a robotic arm to control the coil, and it has some advantage because sometimes the patient move and the arm follow the patient or the movement on the head. Okay, and it's useful, and it's possible. The patients are tired. I think that is good acquisition. Okay, but it's possible not only to collect motor evoked potential, normal motor evoked potential. It's possible to understand better the mechanisms that are functioning in the brain of the patient. If we make pair pulse, one pulse and previously 2 milliseconds previously other pulse, we create we have a motor evoked potential smaller than the normal motor evoked potential. And this possibility is in relationship with GABA system. I don't know if you know what is GABA system. There are different neurotransmitters in the brain, and some neurotransmitters use this neurotransmitter GABA, others use this neurotransmitter NMDA, others GABA. We need integrity of this system for a good recovery. In the normal subjects, we make pair pulse with 2 milliseconds, and the normal is the decrease of the motor evoked potential. We know this because we use a drug that modify this neurotransmitter, the result changes. Okay? If we make 2 pulses and a difference of 10 milliseconds, we have a facilitation, increase the potential. And this action is in relationship with an NMDA system. And if we're making a force, a strength, and make a stimulus, we have a silent period after the motor evoked potential that is in relationship with GABA. That is possible to study the integrity of different systems with pair pulse with TMS. More. This is a kind of stimulation that says theta burst. Theta burst use strains of stimulation. It's possible intermittent theta burst or continuous theta burst. We measure a motor evoked potential, and the patient after receive intermittent theta burst and measure again the motor evoked potential, we see during a minute an increase of the peak to peak the motor evoked potential. And with continuous theta burst, we have an inhibition of the motor evoked potential. But for example, in a disorder, the autism spectrum, what happened in autism? We make the same, and the patient say that the inhibition is more than the normal inhibition, and the excitability is more than the normal excitability. This is an example that I comment in the second slide. It's not good hypoplasticity, but this is bad hyperplasticity. In the autism disorder, there are hyperplasticity. In this kind of patient, the important thing is not to increase the spasticity, it's to find the exact plasticity that I need. There are other forms to measure the effect of TMS. In the last year, we used a lot of EEG. Now there are programs that facilitate to measure quantitative EEG. It's possible to make a stimulation, during 10 minutes use EEG, with the program convert the EEG signal in a map. And it's less expensive, for example, of fMRI. In the last year, there are a lot of studies, and I think this is a technique that increases in the future. Well, this is more about the neurophysiology. Now to pass to the use in clinical of non-invasive brain stimulation. This is a summary of the use of transcranial magnetic stimulation in clinical use. We use not only one pulse, we call repetitive pulse during 15-20 minutes. Two kinds of stimulation. We use low frequencies. Low frequencies is 1 hertz or less. During 15-20 minutes. Usually we wet inhibition. And we use high frequency. High frequency is 10 or 20 hertz. Usually we wet increment the excitability. And this is the base of the treatment. You want to increase the excitability, use high frequency. and I want to decrease the excitability, and use 1 Hz. This is the simple scheme or the summary of the use or RTMS in clinical. First, I want to demonstrate with this video that we have an acute effect with repetitive TMS. It's possible with repetitive TMS to change the function during a few seconds. This is an old video, you see the 1991. But I think that it's possible to listen. Okay.
Okay, start reading.
Cicle helps prevent stroke.
Try the other
He's
side.
reading,
Okay.
It's in the right side now.
Symmetrical here. Yeah. Okay, start reading.
The threat of stroke requires early intervention. Cicle helps prevent stroke. 48% more effective than aspirin with a p-value of 0.0004.
What's the difference between both sides? I don't know. If in the first is a moment when it's reading that stop to reading. You know that the capacity to speak in the right hand people is in the left. The right moment with the stimulus, not the patient, the subject in this case, lose the possibility to read. When we stimulate right side, no problem, okay, because the language logically is in the left side. Now in the second video, the subject is singing.
And push it and start.
Swing low, sweet chariot, come and carry me home.
On the left.
Swing low. That was interesting.
Okay, start singing.
On the right.
Swing low, sweet chariot, coming for to carry me home. Swing low, sweet chariot, coming for to carry me home. Swing low. Okay. That was bizarre.
It's a question for neurologists. How is possible this? In the second, when you stimulate the left side, no problem. When the subject is singing. Because the prosody, the reed of the speaker, of the singing, is not in the left, it's in the right. When we are singing, not speaking, it's notes without meaning. Okay? And the control of the rhythm of the speaking or the singing is in the right. It's the reason because we stimulate when the subject is singing, when we stimulate the left side, okay, there are no changes. When we stimulate the right side, the subject loses the rhythm of the. Bueno, now it's not a surprise, but this is the 1981 when the people start to experiment how it's possible to modify the brain with the transcranial magnetic stimulation. And this is the other tool, TDSS, transcranial direct current stimulation. For me, it's like, I suppose that it's like a black box. Nobody knows exactly how work TDSS. TDSS is a simple system. Battery, this is the first device. Now it's more sophisticated. First device. This is a battery, an anodes and cathodes. And we create an current, electric current of 2 milliamperes. It's not like electroshock. The patient only feels like a tickling in the scalp, but no more. No. Nobody knows how it's possible that with only 2 milliamperes, in relationship with the position of the anodes and cathodes, it's possible to get changes. The principal hypothesis is that we create changes in the extracellular matrix and indirectly change the ionization of the interneurons. But it's more theoretically, and it's not clear what's possible to. But we have not a motor evoked potential when you use TDSS. I put the TDSS and collect with electrodes the hand and inoculate and motor evoked potential. But it's possible to measure the consequence of the TDSS. The first studies demonstrate that we take a motor evoked potential. After I do TDCS during 20 minutes and collect again a motor evoked potential, and if I use an anodal stimulus, increase the motor evoked potential. And if I use a cathodal stimulus, I decrease the motor evoked potential. Then, which is difficult in vivo to demonstrate the directly effect of TDSS, we use usually mathematical composition according with the position of the anodos and cathodos. It's possible a mathematical prevision that the currents affect different areas of the brain. You see that TDSS is less focal than TMS. But in the last years we have a high definition TDS, and it's possible to get a more focal effect. But until now it's more focal the effect of a coil of the TMS. Then with repeated TMS it's possible to get a motor evoked potential when we use an stimulus, suprathreshold stimulus. But with TDS, it's impossible to arrive at suprathreshold stimulus. Only is possible to measure the consequence of use of TDSS. For example, this is a real case. It's a patient with brain damage for anoxia, loss of oxygen because of heart failure, and a young woman. With 6 months of evolution and in a state of awareness with a response. It's like a vegetative state, more or less. Bad prognosis, a patient with 6 months of evolution in this state for brain anoxia, he has a bad prognosis. We use an off-label use of the TDSS to stimulate dorsolateral prefrontal cortex, because I previous studies that demonstrate that some patients that stimulate dorsolateral prefrontal cortex, perhaps it's possible that improve. This is the functional MRI. It's a technique that resting state fMRI, because the patient logically is impossible to give orders. It's impossible to say the patient see you or give a sound or with something. It's impossible because the patient is in vegetative state. This is the first before and this is the after 3 weeks of TDSS. But the patient is a patient with 6 months of evolution. It's not a acute patient. You see that the person that analyzes this fMRI, they have not idea about TDSS, rehabilitation, or anything. If you compare the previous and the second fMRI, in saying this kind of technique that measure the amplitude of the low frequency fluctuations, you see more, in general, in all the brain, in all the cortex, one increase of the amplitude of the fluctuations. But it's more interesting this. This is a study, the connectivity. Points of the same color means that they have connection, okay? You see that low level of connection between frontal areas and posterior areas. But after the TDSS, it's possible to see more connection between frontal areas and posterior areas. And curiously, this is the dorsolateral prefrontal cortex. It's easy to know the relationship between the TDSS and the results. Unfortunately, the patient don't pass to the next step. When the patient is in vegetative state, the next step is to go to the minimal response phase. And the patient, with this technique, they have more open eyes, more movements, but they are not an improvement in the cognitive point of view. But only want to demonstrate that it's possible with the TDSS, we get changes. I don't know why, and it's possible to measure. There are now, in the last years, other techniques of electrical stimulation. There are some studies with alternate current. And especially with this technique is random noise stimulation. This is an alternate current, the high frequency. It's like create noise in the brain. The idea, if you equalize the brain with noise, okay, and then starts one rehabilitation exercise or one cognitive exercise, we reinforce this exercise. This is the theory, okay? A summary. There are advantage and disadvantage of the TDSS compared with TMS. TDS is more portable, is less expensive, allows simultaneous to do this with peripheral training. For example, it's possible to make, for example, rehabilitation of the walk, or for example, it's possible rehabilitation of the arm at the same time that I put the TDSS. With TMS, it's difficult. Usually, we use a serial approach. We first with TMS, and after that, make the rehabilitation. It's more comfortable TDSS. Usually, fewer side effects. TDSS really only some patients have headaches, and we have one problem of burn in the skin one time in 20 years in Guttman. TMS is safe, but they have the possible effect of the burst to have a crisis, epileptic crisis. One case each 10,000 in healthy people. But TDS has less focality of the stimulation than magnetic, and logically, that I comment, TDSS has non-measurable effects. And the strategy to use TDSS, TMS in rehabilitation is this kind of approach. Because I'm not interested in the acute changes that produce the TMS or TDSS. I'm interested in the capacity of modulation. What do you want? To modulate a specific brain networks, and during the few minutes when change the modulation of these networks, we start with the rehabilitation, cognitive, physical, etc., etc. This is the model of rehabilitation. To change the brain, a few minutes, to take to entry with some exercise or with some rehabilitation exercise to get long-term effects. Okay? The acute effects is not interesting. Another question that is important to explain. We don't treat disease with stimulation. We treat symptoms, disabilities, problems. There are people that write me, I have the multiple sclerosis, I would like to, if TMS is useful for me. No, it's not the question. We treat pain, we treat depression, okay, we treat loss of force in the arm, in different disease probably, but this is the important thing. We treat symptoms, no disease. And, well, good. It is the list of different clinical applications for clinical programs or for studies of transcranial magnetic stimulation and TDSS. In red, Guttman have some kind of experience, different experience of clinical programs or some kind of studies. We remember in the world, principally in USA, the principal use of transcranial magnetic stimulation is in depression. Okay. The FDA is the organization that approves the drugs and the devices. That is necessary for it because if you want to get the assurance cover the treatment, it's necessary that the FDA approve this treatment. But in USA, transcranial magnetic stimulation is approved for depression. It's important. TMS, TDS are safe, but there are safely guidelines that is important to follow, because if you follow this, in my experience, and it's a safe technique, but it's important to follow the guidelines, the international guidelines that are published, and each a few years there are a new publication, a new report about the actualization of the security guidelines of the transcranial magnetic stimulation. If you want to read some paper in relationship with the clinical use of TMS, I recommended this. This is a review, it's the second review that analyzed the level of evidence of the use of the TMS in different problems. And this is the last published in the 2019 this is the last in the 2019 was published as the last review. And in those letters are the indication with A, B, or C level of evidence. Okay, but I remember that in depression, in chronic motor stroke, in relationship with the arm, and in pain, neuropathic pain, this panel considers that there are a level A of evidence to use in clinical practice. And now I want to talk quickly about our experience in different problems in Guttman. First, in spinal cord injury. Okay. The first question, the spinal cord injury, the kind of coil that we use is this kind of coil. It's not like a focal coil. We have a conic coil. Why? Because this is a representation on the pain homunculo. This is the motor representation of the cortex. And you see this is the hand that I commented before. And there are the legs. The legs is in the sagittal, in the central area of the motor cortex. Okay? Then it's better to modify the suitability of the leg area to use this kind of coils. It's not focal, it's more focal the 8th coil. They have more expensive stimuli. But that is the best option to try to modify the motor area of the leg. And the principal use is to improve spasticity of walk. And we have the model that I commented before. First, we make 20 minutes of stimulation. We use high frequency stimulation, usually 20 Hz. And after that, we make 1 hour of rehabilitation of the walk. This is Dr. Akunru. Dr. Akunru is the principal author of this kind of studies in Guttman. And this is the effect in spasticity. The effect on spasticity is possible to see after one session. I remember the study. You make a stimulation and you see an acute change in the spasticity. Spasticity, I don't know, you know what is the spasticity? It's the rigidity after a central lesion on a stroke or a spinal cord injury. Sometimes this rigidity produces pain and difficult the movement of the patients. This is from the visual point, from the subjective point of view of the patients. It is with a specific scale in spinal cord injury. And after the last session, we make 5 sessions in this study. The change remains, and 1 week later remains the difference between the two groups. We make active stimulation, and the other group make some stimulation. Okay? And this is the result in gait. If we measure the low extremity motor score, all the patient improves in general, because this patient is in acute phase. It's in acute phase of rehabilitation, and the patients improve. But improve more the patient that receives stimulation and the velocity of the gait. The difference remains after a week, but in this case we have not found statistical significant evidence about the difference between both two groups. Other question is, what is better, to make TMS in the sequentially form, first TMS and after that rehabilitation, or is possible to improve with TDSS in the same time or we make a rehabilitation of the walk? Then design this study with using Locomat. I think that Dr. Eloy Piso explained the other day. Locomat is an exoskeleton, but fixed, and the patient is hanging while he's walking. Logically, with TMS, we have the sequence. First the TMS, and after that, Locomat. And the patient with TDS is possible at the same time to make TDSS and Locomat. We can do this kind of design for groups. Some TDSS, other active TDSS, some RTMS, is some active RTMS. We have not found results with TDSS. All the patients improve in the two groups, but there are not significant difference in the motor score between active and some TDSS. There are no difference. But we find difference if you analyze the TMS group. And it's curious, because if we measure in the subgroup the patient with cervical lesion, because if you have a cervical lesion, not only you have problems in the legs, you have problems in the arms. We analyze the subgroup, the patient with cervical lesion, improve the arm. It's logical, because conic coil is not also focal. Active the legs, with this position, active the motor area of the hands also. Well, this experience is possible to translate other disease. For example, multiple sclerosis. Multiple sclerosis, there are different studies published with TMS, TDS, multiple sclerosis in relationship with spasticity and function, fatigue. And now we have Carlos III grant to study the TMS in multiple sclerosis. We start a few months ago. We carry on 9 patients until now. I follow in 2 years to know what's the result of the study. We make 2 weeks the TMS with rehabilitation of the walk, and logically with active and some, and we make functional MRI before and after the stimulation, the 10 days of stimulation. Okay. Other possibility, the non-invasive brain stimulation in spinal cord injury is to treat the pain. patients with a spinal cord injury sometimes have neuropathic pain. I don't know if you know what is the neuropathic pain. Neuropathic pain is a strange pain that have the people with neurological damage. Sometimes it's similar of the pain of the phantom limb pain. You know what is the phantom limb pain? People, amputated people, sometimes feel with pain the arm or the leg that they haven't. This is the phantom limb syndrome. Sometimes spinal cord injury patients don't feel above the lesion, but they have pain. How is possible? How is possible? Because above the lesion was create memory pain circuits that say at the brain, you have pain, you have pain, you have pain. Okay, this is the central neuropathic pain. Central neuropathic pain is difficult to treat. There are no response to analgesics. Sometimes a middle response to antiepileptics or antidepressant, but with no good results. The idea is there are Dolores is a psychologist, but interested in pain. And this is the base of the doctoral thesis. We designed this kind of a study. We know the person with phantom limb, if we make a play with mirrors, and we get the possibility that the brain think that the patient recover the hands, okay? This is in phantom limb. Sometimes the patients improve. It's demonstrated. There are in New England a few years ago that demonstrate this. Okay, we have to reproduce the same idea. We create a system. Okay, now it's more sophisticated because now we use virtual reality glasses because in this moment we have not virtual glasses to reproduce this scheme. With a mirror for the patient, imagine that your self-image, no? And now we have a reproduction of the two legs moving with the sound, okay? And add TDSS in the same time. Then we make a study with 4 groups. One group, TDSS active, and this kind of system, okay? The other group, TDSS active with a video, like a distraction, there is no video, a film, okay? Other group, this kind of system, but some TDS, and the other group, some TDS and a video and a film, okay? We have the possibility to have 4 groups in the blinded study. But the study in relationship with TDS is impossible to make the blended with the video, okay? And we demonstrate that the group that receive both two systems, TDSS and imaginary, improve after the 10 sessions of TDSS, and the difference remains 12 weeks after the intervention. If we analyze the groups, there are more changes in the group that receive TDS con virtual reality or virtual imaginary, and the group with TDSS. But if we analyze the group with only TDSS, there are a lot of changes. There are patients that improve, but there are patients that worsen. But this is the group of the patient that receive both two. This is important because that I commented previously, TDSS modulate, but it's important which is the program that adds to the stimulation to try to carry on the modulation in the correct way. Now we have an international program to understand better the mechanisms of the use of TDS. We studied that there are not only changes in pain, there are motor changes with TDSS. And we're making a study to know what is the interaction between drugs and TDSS. Now we finished the recruitment of this study, and I expect that the next year we have some results. Okay. Now use this kind of system. Now we don't use. This is an example. A few weeks ago, the patient received TDSS it's possible to both two. It's easy to make both two in the same time. To the TDSS glasses and the virtual reality glasses and with TDSS. Quickly, this is not brain stimulation. This is a spinal stimulation. Everybody knows in the last year the studies of the Switzerland group with epidural spinal cord stimulation to improve the walk. In the notice and in the newspapers are the 3 patients that improve with epidural spinal cord stimulation. Our idea is that it's possible to improve the patients with non-invasive electrical spinal stimulation. Okay. This is not like TDSS. This is not 2 milliamperes. We use 30, 40, more than 100 milliamperes. It's not nice. Sometimes the patient feel pain. Okay. We have 2 kinds of studies to improve the hand and to improve the walk. In the case of the hand, we put the electrodes in C3 and C6, and in the case of the walk, we put the electrodes here and the electrodes here. We start now. There are 2 doctoral theses to try to investigate this design, and I expect this is the stimulator. This is a Russian that living in USA that create this kind of stimulator. I don't know. We will have problems in the last months with this situation. And this is the electrodes, and this is the physiotherapy that voluntarily accepted the stimulation. Okay. Quickly, we have experience in stroke, to improve the hand mobility after the stroke. To explain what is the technique of TMS in the stroke, it's important to explain the concept of paradoxical facilitation. In the normal subjects, we have a balance between the 2 hemispheres, because the hemispheres send negative or send inhibition signals to other side for intracallosal via. Okay? If we will have an injury, we have a problem. Not only for the injury. You have an injury, the healthy side continuing to send inhibition, but the damaged side or the injury side don't send the inhibition. Then the balance is broken. Then we have 2 possibilities to return the balance of the previous situation. 1, increase the excitability of the damaged area. But the other possibility is to decrease the excitability of the healthy area. And curiously, in stroke, in most of the studies, use more this second action. How is possible? Logically, if we want to, this is the healthy area, it's possible to inhibit this area with low frequency TMS or with cathodial TDCS. And if we want to increase the damaged area, we use high frequency TMS or we use cathodial TMS. Why we use more inhibition? Well, this is an example of a study with high frequency TMS. The problem is this is the lesion after a stroke. Where you put the coil? With an image, it's impossible to know. Okay, because I stimulate this area, I stimulate nothing. We need an image, we need an fMRI to know with fMRI what is the areas that is possible to stimulate. This is expensive, it's difficult to interpret, etc., etc. It's easy for neurophysiology to find the motor area and contralateral area and innovate. Another question is high frequency. The risk of epilepsy is higher than with low frequency. Then most of the studies use low frequency in the healthy area. Okay. There are a lot of studies with. This is a review. Now I more studies. This is a review with in 16, but there are a lot of studies. But more of the studies. This is only 4 studies in the acute phase. All these other studies is in the chronic phase. The number of the patient is, the total number of patients is more than 500, but there are different, there are studies with 8 patients and the studies with near of 2 patients. And most of the positive results is with innovation in chronic patients. It is a problem because in the real life it's easy to, patient with a chronic phase, it's difficult that in the public system pay us for attending chronic patients to make this kind of treatments. I would like to know that it's possible in acute patients that not only have a problem in the arm, have problem in the speech, problem in the walking, neuropsychological problem, it's possible to add TMS to improve the prognosis of the arm, to try to resolve this question. Now we have this grant, of BBV grant, which is the doctoral thesis of Nadia. We try to use TMS in the Guttman rehabilitation program, okay? With a double loop, with some controller with some, okay? This is a first cut with 15 patients. And this is from the poster in the last week. And it's interesting because we analyze this is 2 of the most important scales of our movie, and you see that the figure major and ARAT is the most important scales on the movement of the arm. The patient with the ANOVA analysis improve when we finish, and in the follow-up, 1 month after we finish, the difference remains. I think that is good. When we finish, I expect that remains these results when I finish the study. We use the same technique for aphasia. We innovate the good side to improve the injury side. You know that language problems in the right hand people is in the left side. Then usually we innovate right side. With the right side model, we look there. The studies, the first studies, was made for Nausser in Boston, that discovered in '95 that the best point to innovate is this pars triangularis in the bronchial area in the right side. Sometimes with innovation it's possible to have acute changes. This is the case of the patient. I put the video. This is a Boston naming test. We put some drums on the patient, and the patient have to name with the aphasia problem. This is the before the stimulation. Okay.
That's fine.
Reina 1 New Gaza
It's difficult to use American and put the rugby ball.
Guabinho
I think that 2-3 words.
Yeah.
Is after a session of TMS.
Vinta Grau Gaspar Dit Avión Casa no sé Urubru
You see that the patient improved. This is the acute change. Usually in the real world, the world is not also spectacular. This is a case of a spectacular change, no? But this is, as I commented before, the interesting is not the acute change. The interesting is long-term change. When we use TMS, and after that, 2 hours of speech therapy. Okay? With a kind of speech therapy that is constraint-induced language therapies, in special speech therapy that we don't know, that we know that is useful for this kind of patients. Okay? This is a program, it's a clinical program, this is not a study. Unfortunately, now it's a private program. I expect that in the future we have some public program. And we collect 40-45 patients. This is the results of the first 20 patients. Most of the patients, all the patients is more than 6 months of evolution. Sometimes patients are 2 or 3 years after evolution. Logically, we select the best patients. Not all the patients with aphasia, with motor aphasia, go into this program. And we know improvement that remains after 6 months in the Boston Dynamic test, in the grammatical test. There are studies in disease, in degenerative disease with speech problems. We have no experience, but now is studies in frontotemporal dementia and for example, in language problems in people with Alzheimer, with this technique, principally with DDSS. This is the last 2 slides. I don't know, would you know the syndrome de Meij? This is more specific of neurology. Do you know dystonia? Dystonia, okay? The movement disorder. One of the more frequent movement disorder is blepharospasm. The patient open and close the eyes, forces open and close the eyes. The problem is the dystonia of the orbicular oris, the muscle around the eye. But some patients, we have no problems with this, problems with all the face, including sometimes the vocal cords. This is the syndrome of Meij. The treatment of the dystonia is difficult to treat. Dystonia. Usually we use botulinum toxin, okay, to try to reduce the movement. But this is a kind of, it is a patient with bad results with the botulinum, okay? And this is an off-label use of these techniques because we know that the problem of the dystonia principally is a problem of the basal ganglia. But we know that there are a participation of the cortex. And in this patient, that increase of the cortical excitability. The idea is to inhibit the cortical excitability to reduce the movements. This is, okay, sorry. this is the history of the patient. Okay, final.
Pues lo comencé con blefaroespasmo yo creo que unos 5 años. 7 años, vale. Pues 7 años, no sé, hace mucho. Y al principio solo me molestaba al conducir.
The patient needs the possibility to drive.
Se fue
The
incrementando.
patient probably drive. All the time
tuve un
is
tratamiento
possible for the patient to
toxina
drive.
botulínica. Y hace 3 años empezó el problema de la voz también. Y bueno, se generalizó la distonía facial, por así decirlo, ¿no? Dejé la toxina botulínica y bueno, pues ahora ya estoy aquí viendo a ver si está.
No puedes.
¿Ya?
Sí.
Bueno, pues ahora me encuentro más relajado. He estado pues, casi una horita llevamos aquí, ¿no? Sí. Y creo que estoy un poco mejor, pero no lo sé, ¿sabes? Desde luego estoy mucho más relajado.
¿Cómo notaste la otra vez, el primer día, la otra vez?
El primer día, por la tarde, sí que noté una mejoría muy grande que duró, yo creo que un par de horas aproximadamente. Sí. Sí. Fue muy bien, la verdad. El primer día. Los siguientes días ya fue más diferente. Y los últimos días ya
estamos.
Te comento
But no improve more.
Hoy es el segundo día, tercera sesión.
Curiously more in the face.
Creo que estoy, pues, un poquito más relajado que antes. Y
2 months, 3 months, and we repeat.
en la sesión pues he estado muy
And
relajado.
after 2, 3 repetitions, we recommend you to put toxin
No
again.
sé qué más quieres que me cuente.
¿Qué has hecho el doble día?
¿Qué he hecho medio día? Pues hemos dado una vuelta.
Okay. Bueno, I am is the one of the. I think that only 3 or 4 slides to finish. Well, you remember that the more used clinical use of TMS is depression. FDA approved devices, not approved techniques, approved devices. This is all the devices. This is the first devices they approve. FDA. It's a device that only is for depression, okay? But now we use more this kind of devices. This is the devices that we have in Guttman. That's only not only for depression. It's possible to use for the clinical approach. Bueno. In depression, it's important to know that depression really, in fact, is not a disease. It's a syndrome. We have different kind of symptoms in depression. We have dysphoric symptoms, sadness, anhedonia, lack of concentration. In the studies, it's localized in dorsofrontal polar left cortex. This is the point approved for stimulation with high frequency in depression. But we have other problems. For example, axiosomatic symptoms, sleep disorder, sexual and nutritional behavior changes. And we know that perhaps in this case, the best place of stimulation is not here, it's here. And there are some patients that improve when stimulate the right side. The future, the idea is to personalize better the indication of depression. And logically, if in dorsolateral prefrontal cortex improve sadness, anhedonia, lack of concentration, perhaps it's possible to improve this in other diseases. This is a study in elderly people. Elderly people, normal. Elderly people sometimes have problems of attention or in dual task. Do you don't know the dual task? Dual task is the possibility, for example, to walk and to think or to make an operation or make a mathematical operation or think or talking at the same time that I'm working. This is dual task. When some disease or elderly patients lose the possibility to make well dual tasks. But we stimulate dorsolateral prefrontal cortex in elderly people with TDSS. There are studies that demonstrate that improve in executive functions and performing dual tasks. Then there are studies with dorsolateral prefrontal cortex in different diseases, in pain, in working memory, in improvement in inhibitory control, in reduce the perception of fatigue after the exercise, like electrical doping. This is some studies in sport to use this kind of techniques. And logically, it's possible to make studies in different diseases because this kind of problems is possible to see in multiple sclerosis, Alzheimer, Parkinson, etc. But by comment, we don't treat disease, we treat problems. And the last question, this is more interesting question. It's a program that direct or research director, Dr. Termos. I don't know if you listen the concept of prehabilitation. Prehabilitation is a concept of in surgery. People, before the surgery, you make a planning of exercises, of aerobic exercises usually, and then improve the prognosis after the surgery, less days of admission in the hospital, and less problems after the surgery. This is the concept of pre-surgery. We prepare the patients before surgery. This is more ambitious concept of rehabilitation. If we have a surgery for a tumor, it's possible to prepare the brain to have better recovery after the resection of the tumor. This is the idea. We can modify the plasticity, for example, to increase the function of this area out of the tumor to get the best functional recovery. And other possibility, it's possible to reinforce other parts of the brain and then to increase the possibility, the resection of the tumor, because we powerful this area, then let us to increase the margin of the tumor resection. And then we have a best functional recovery, but we have best tumor prognosis. This is the idea. To modify the plasticity, we use TMS, we use TDS, we use rehabilitation programs, etc., etc. We start now. I finished 2 patients. It's not a normal study because the patients are different according to the position of the tumor, and it's difficult to collect new patients. But it is more interesting because I imagine in the future that it's possible to prepare the brain to have a best recovery, to have less problems after the surgery. To finish, it's possible to recommend in this moment the use of non-invasive brain stimulation in the clinical practice. A failure, but they are safe techniques if the recommendation of the guides are followed. There are evidence of efficacy in some use, no less than other techniques introduced now in rehabilitation. They are compatible and probably synergistic with different rehabilitation therapies. And in general, it's a well-tolerated technique. But we have some problems, logically. There is still not enough evidence of the use in most rehabilitation process. There are no generalized protocols for the time of completion, repetition, or what is the most appropriate moment to introduce. In many cases, we don't know which are the best rehabilitative therapies that is necessary to add to the non-invasive brain stimulation. And there is not a standardization of the technical condition of administration, perhaps only in some disease like depression. And this is all. I think that, I don't know if it's in time or... Unless you have some questions.
Thank you, Raul, for your lecture. Very interesting and very with a lot of ideas and also a lot of questions to share. We have some questions, comments, reflections, doubts, suggestions, whatever.
Well, in the last part of the presentation,
Yes.
you only talk about CNS, where mostly focused
Yes.
on it, and no TDCX.
Mm-hmm.
Is that for some reason? Because, like, perhaps...
No, I talk about our experience. So, we have now we have a program with TDS in pain. Okay? We prefer, there are positive results in TMS and TDS, but our experience in TDSS in pain, we use programs of neuropathic pain in TDSS. And we have some study in functional neuroskeletal recovery with TDSS. I think that for cognitive studies, it's more useful TDCS, because it's easy to perform, and sometimes a lot of studies in elderly people tolerate well better TDCS than TDS. But we have, in our case, more experience with TDS. But the idea is to introduce, for example, in the comment before, and during the COVID lockout, during the lockdown in USA, people that receive TMS with good response to depression, some problems to go to the hospital with the lockout. Okay? And then FDA approved the possibility of these patients to use TDSS at home. Because the future probably the TDS is at home. There are some studies. The idea is possible because when you go into the Amazon, there are people in USA that send a battery with analogous cathode to the disease without control, etc., etc. The problem with TDSS is easy to use. It's less expensive. And it's the dangerous because sometimes it's like a game, no? I put it on the patient is okay, no complications. This is the danger of this kind of systems. There are a lot of studies with a small number of subjects, and it's not necessarily a cure for learning, because for TMS you need a lot of days to learn to use, to understand, okay? But with TDS, in 2 days, your patients, possible to learn in 2 days, the use of TDS. But, well, this is the question. But I only talk about our experience, not about in this moment, it's uses more TDCS than TMS, for this reason.
And for example, for Parkinson disease, what would you recommend?
For Parkinson disease, there are level AD evidence that you make a stimulus in some patients, include the walk for minutes. There are spectacular videos. That you say to the patient, you stimulate, the patient can start. But there are no guidelines how to introduce these techniques in your rehabilitation program on Parkinson disease. And some studies in depression. There are people with Parkinson's disease and depression, because you know that Parkinson's disease is usually that they have depression, and there are, yes, sometimes it's the first symptom of the Parkinson's disease, depression. And there are people with depression that use in the program refractory depression with TMS. There's some cognitive studies with TDSS in Parkinson's disease. But more interesting is the walk. The problem with the walk is sometimes it's spectacular. It's like the patient that we use 20 minutes of TMS, during the 5 minutes, work better. The problem is nobody knows that if you incorporate this in a rehabilitation program, we have long-term results. Okay?
But for example, you said it improves the walking, but the arms, they can move them better.
I don't know read studies with arms. Perhaps it's possible, but I don't read studies with arms in Parkinson's disease. It's possible that they exist.
I have a question about, because when you talk about these two ways of stimulating the brain, you do it in short periods of time, let's say 20 minutes. Is there a way maybe of extending the process, like doing it throughout the day and do 20 seconds, depending on the variables of a person?
This is the question. How many times, how many days? This is the important question. About, in relationship to the time, the studies is between 20 and 30 minutes. There are studies with TDSS, we do remain the stimulation more than 30 minutes, some patients worsen, not improve. And there are some studies of safety with TMS. This margin is a relationship with the safety of the TMS. We have not clearly that more time is safe. This is one question. More or less, the time of the stimulation probably is near 20 minutes. The problem is how many days. The limit is in relationship with the feasibility in reality. Because one question is, well, these programs are 2, 3, 4 weeks, no more. Why? It's because the real world sometimes is difficult to do more. And Tony Valero is a scientific that studied a few years ago in cats. We make a surgery of the right side of the cat and produce immunoglobulins. Immunoglobulins, you know the immunoglobulins, the cat don't pay attention for the things in the left side, but you have a right side lesion. And stimulate the cat all the days, Saturday, Sunday, doing 3, 4, 5, 6 months, and get to the changes without necessity of rehabilitation. We analyze the pathology of the brain. We make changes, not only because this is a focal. We only use the focal. We will produce changes in all the network. For example, in pain, we stimulate hand motor area. Why? The idea is because there are a lot of connections with thalamus. It probably is a door to go to the thalamus. The thalamus is very important for the control of the pain. Probably we will repeat stimulation during weeks, perhaps we remain long-term changes. But it's difficult in real life. The idea is more than we have rehabilitation. It's possible to accelerate the process. For example, in the arm, we know that in chronic patients with problems of the people say, there is no plasticity after the acute phase. It's a lie. There is plasticity after the acute phase. There are studies, in England published a study 2 years ago, the patients with problems of the heart, but some kind of movement. After the stroke, chronic patients, we have a 1 each day program of rehabilitation, intensive rehabilitation, all the day. The patients improve. The problem that is possible for the system to cause this kind of. If you will possible to demonstrate that even necessarily 3 months and with 2 or 3 weeks, your TMS accelerate the process, we reduce the cost. The thing is that for me the idea of stimulation, the idea is it's possible to get targets with less time. Use this is really that. But nobody knows about it. For example, depression patients improve, and how many times do we have time this is improved? Some patients 2, 3 months, 4 months, some patients 1 month only. Then it's necessary to repeat. Each person, each patient have different rates. For pain, for example, I have experience with pain. Some patients improve the pain, but only during 1 week. And other patients during 4, 5, 6, 7 weeks. It's different in each patient.
In the example you explained that when you have a stroke with TMS, you innervate the healthy area. Do you provoke less power in the area?
In the subacute chronic phase, there are a lot of studies. That I don't know why. It's a question of reorder of the network. The patient don't work, or functionally don't work. It's not clear in the acute phase, because in the acute phase, the problem is the brain is different. The acute phase is more important than recruitment in the recruitment in the good side. Perhaps in the acute moment, it's better not to touch the theoretically, because now we have the study with people between 3 to 6 months after the stroke. We know the result, but it's an interesting question. But in chronic phase, nobody published worsening in the good side. In these conditions, in these conditions that.
You explained that these two techniques have some positive points and negative points. Isn't that possible to have a device with all the positive points of both techniques? Let's say the TMS, portable TMS or something like that.
No, TMS portable, we have different. The most simple device of TMS is like this side, not the coil. I don't know what this. Perhaps it's possible, but no. I don't know if that's some device that with TMS, small TMS, no. I don't have chips that big. Sometimes. It's possible to create a machine with a tower. Most of the machines of repetitive TMS need a lot of power. Another problem is with the repetitive TMS is the increase of the temperature. Because in the first coils we need to put freeze after. Now we have ventilatory systems. With water or with air systems, and then the coil is bigger.
But maybe it's in the future we can get this technique. At the beginning we have mobile phones, very huge mobile phones, and now we have small mobile phones. Some physicians have Dopplers that
I think that
even the.
I don't know, perhaps if Lloyd's here, I asked about that. Perhaps if until now nobody invented small TMS, perhaps technical difficulty before. Then it's important to ask an engineer that it is possible or it's not possible.
Okay, something else? As you see, you can have an important work to do, working with us or in health institutions to design devices for helping people or to participate in clinical trials, research, whatever. So I think that.
For example, modeling combinations or mathematical models to know what the different combination of electrode it's a field more important because you sometimes buy the program, but the people in the program that create different systems, that mathematical and physical and engineers that create different combinations, different models to improve the position of the electrodes. More interesting.
So thank you, Raul, for coming here and for sharing with us your experience and your ideas with these new techniques. So thank you very much. Today is the last day of the class.